I would like to thank the organizers for this fantastic meeting and to invite me here. It is always a pleasure for me to be here. I was asked to speak about painful chronic AC joint dislocation, and this is for me actually to speak about the symptomatic AC joint dislocation, because we know that not all of the chronic instability cases are really symptomatic. So the patient has pain, shoulder disability, and deformation. And rather than describing them separately, in my opinion, they are connected in between. There are connections in between. So deformation influences the pain, and pain influences disability, and so on. We know that the pain is over the AC joint, about the posterior shoulder region, around the coracoid. And the pain can also irradiate to the cervical paraspinal region and lateral aspect of the arm. And some patients also describe radicular symptoms. In my opinion, we can describe the pain origin as intra-articular one and extra-articular one. And intra-articular pain comes from the ligaments and injury to the articular surface and when bones rubbing together. And you might have those cases with osteolysis of the distal clavicle after a few months, or especially in a grade 4 when there is clavicle engaged to the acromion, and this might be very painful. And the second thing, extra-articular origin of the pain, I will discuss a little bit more in this talk, is related to the changes in the position of the scapula and also on the biomechanics of scapula. So when we examine the patient with AC joint dislocation, it is not only important to see only the AC joint, but we have to have a little bit broader view. So this is a patient with a right AC joint dislocation. We can see a protraction of the shoulder and some winging of the scapula. We know now for a long time, for a few years, that patients with chronic AC dislocation have scapular dyskinesia in up to 70%. We can find sixth scapula syndrome in up to nearly 60% of the patients. And this is probably the group of patients who might develop persisting shoulder pain. So the scapular biomechanics, as described by Beitzel and so on, is very important. This is the shoulder triangle, which gives us one limb of the triangle on the clavicle and another one on the scapula. And we have to know that clavicle and scapula align the glenoid in appropriate plane only if they work together. On the medial part of the clavicle, we have AC joint, and this is actually the hinge around where the shoulder moves. And on the level of the CC ligaments, or on the level of the AC joint, there is a point where the scapula swivels on the clavicle and moves around the trunk. So when we evaluate the patients clinically, we of course evaluate the instability in vertical and horizontal direction. And I usually examine also the range of motion of the patient and pain. And you can see that the patient has a pain in when they are symptomatic in anteflexion and other motion where scapula comes into the protraction. I'm sorry. And we can see also how patient has dyskinesia of the scapula, like here on the right side. Yes. And almost all of the patient with chronic AC joint dislocation has some grade of scapular dyskinesia. And for the intra-articular pain origin, we can test the patient with active compression test and a resisted extension test and cross-arm abduction test to see if the joint is really painful and how this influences the condition. And sometimes if you do like a scapular retraction test with when you fix the clavicle and scapula together, you will be able to see that the patient can move the arm more freely without of the pain. And this is for me the sign if the conservative treatment will not be successful, that operative treatment can lead to a good result. There is a publication which tells us something about the conservative treatment, and it was shown that in a period of the rehabilitation of 12 months, some of the patients can reduce or can get the scapular control, so the scapular dyskinesia problem is reduced markedly, and also the thick scapular syndrome. So the rehabilitation of the whole shoulder girdle, and especially the rehabilitation of the scapula, is very important in those patients. And if there is no response in 6 weeks, you may consider the surgical treatment. So, but it is always warranted to begin with rehabilitation in those patients. This is a case of a patient with a chronic AC joint dislocation. After here down you can see a little bit of osteolysis, which was seen after a few months. But the patient actually do well with this kind of deformation. But also you can see that here on the right side the scapula is quite well controlled. So in such kind of rehabilitation with good control of scapula, this patient can do well. When we decide for surgery, for me, indication is persistent pain, of course, horizontal and vertical instability, how the patient control the scapula, and we have some patients who are difficult to treat non-operatively, a patient who practice overhead sports or overhead work, and so on. And of course, the patient expectations are also important. My preferred treatment of the chronic AC joint instability is fixation of the clavicle on the coracoid with this suspension system, and with adding the autograft. I'm using the semi-T tendon, which is also long enough to do also AC joint stabilization together. So this can allows me to do near anatomic reconstruction, and this suspension system will protect the repair until it heals. So this is arthroscopic assisted anatomic reconstruction. The first step is to put this suspension device through the clavicle into the coracoid. This is the view under the coracoid. And the next step is just to put in the autograft below the coracoid. I round it up, and I passed with the 2 tunnels over through the clavicle. And this is the picture over the AC joint. And I do this, like I said, with a little bit bigger incision, just to be able also to fix the fascia, because I think this is also important to me, to the patient. So you can see here the result after 2 years of this patient with when it is clearly seen how we put the graft through the clavicle and also through the acromion, just to achieve the good stability of the AC joint. These are clinical pictures of this patient, and also how it's the same from the back, because for me it is important that the patient gains also the control of the scapular motion. So to conclude, I think that when we decide about the treatment or how to approach to those patients, it is important to distinguish between intra-articular and extra-articular origin of pain. And we, of course, know nowadays that scapular biomechanics is an important reason for functional disability. And in those cases, we have to address also this. Conservative treatment might be successful if control on scapula is achieved, and good results can be obtained if we gain the vertical stability, horizontal stability of the clavicle, and also the scapular tract control around the back of the shoulder. So thank you for your attention, and I would like to invite you to join us at the ESCA Congress in Milan in this year, May. Thank you very much.